We ready, Simon?
And we are live.
Good afternoon, everyone. This is the Sunday broadcast of the Black Health Trust. We hope and pray that everybody is good and their families are safe. We have a program outlined for you today that I think will be very educational and maybe even uplifting. Uh, I'd like to say that the speakers today are outstanding. Dr. Barbara, who is the co moderator, uh, who is a public health and managed care expert. I'm going to ask her to pre introduce the speakers now, if she would, and we'll start with our program. And I will give the initial statistics after she lets you know who our speakers today are.
Thank
Dr.
you. I will be happy to introduce our speakers after I give you your short introduction. For those who don't know, Dr. Randall Maxey is the founder of Black Health Trust. One of his more recent initiatives that he found a way to meet a need that many of us were agonizing over, and that is the need for credible information to be made available to our community. But aside from that activity and prior to that, Dr. Randall Maxey has had an extensive career in medicine. He is also has a degree in pharmacology, which gives him a certain degree of a leg up on many of us as we attempt to understand and use the tools that are being made available to us to practice clinical medicine. His area of specialty is kidney disease and cardiovascular disease related to kidney disease. He is the proud graduate of Howard University and is currently in, I won't say retirement, because anybody who goes to work all day long is not in retirement, although he says he's in semi-retirement. He is not only an established expert in this country in kidney disease, but also recognized in our territories and internationally. So with that, I'd like to give props to the founder of BHT. As he said earlier, we are extremely happy to have with us today individuals who are going to share their perspective and expertise on the issues around COVID and how it affects our communities. And going in the order that I think that they're going to present, our first presenter will be Dr. Monique Hedman Maxey, who is a physician and also has her MPH and is currently in her, well, I guess she's about halfway now through her first year in family medicine residency at Harbor UCLA Medical Center. Certainly being in LA now, in LA now, she is having firsthand opportunity to see and participate in one of the major hotspots in this country. And I'm sure she has many insights to share with us. Our second speaker is going to be Dr. Rhonda Moore Johnson. Now, Dr. Rhonda Moore Johnson and I have been bumping around together. She's a little bit younger than I am, but she too is a Harvard undergraduate, and received her MD from University of Pennsylvania, and went on to get her MPH from I've been educated, the Ohio State University. Dr. Moore has had a very successful career which is not over. It is just changing um, view. She has been a clinician. She has practiced in Georgia and Cincinnati and has spent 20 years in the Pittsburgh area as medical director at Highmark Health Managed Care Company, from which she recently left. She is now pursuing her advocacy work and is active with the Gateway uh, Medical Society, which is the local affiliate of National Medical Association, where she has served formerly as president and now chairs the fundraising committee. And then last but not least, we have Dr. Stephen B. Thomas. Dr. Thomas is has the I actually am a little envious of Dr. Thomas because he has an official position as principal investigator of the NIH NIMHD Center of Excellence on Race, Ethnicity, and Health Disparities Research. Now, the reason I say I'm a bit envious is because that is a critical role in this day and time. And I asked him what would he like for me to highlight, and he said that that he's a troublemaker, which we've all been given the permission to be. But he says that right now, what he is centrally focused on is building trust, which is certainly something that Black Health Trust is all about. So without further ado, these are our speakers for this afternoon, and I turn it back over to Dr. Maxey.
Thank you very much, Dr. Barbara Neighbor Stevens, who is also a pioneer. She was a child prodigy that I met when she was 15 years ago. 15 years old, and that was just a couple of years ago that I met her. She graduated from Harvard University, from Tufts New England Medical Center, from University of Tennessee, has been affiliated with Meharry Medical College and educating other pediatricians. And she now is a corporate officer of a Tennessee-based managed care company and has been of immense help to the Black Health Trust. And I welcome you again and again, Dr. Barbara Neighbor Stevens, in addition to being a good friend for years and years. Many of you may ask why we give so much attention to the National Medical Association. Well, for your information, the National Medical Association was founded in 1895 as a result of Black physicians not being permitted to join the American Medical Association. In those days, if you didn't belong to the American Medical Association or its local branches, you could not practice medicine in hospitals. It was a requirement that you belong to your county or city medical association. So we were locked out. And if your patient needed hospitalization, you had to turn it over to a Caucasian physician who was permitted membership in those organizations. So our forebears started the National Medical Association. And since that time, we have fought and struggled for health equity, for the equity of our physicians and the patients that we represent. So we represent some 35,000 plus African-American physicians and the communities that they serve. We do have a convention usually once a year. We didn't have it in truth this year, except virtually because of the pandemic. But we have the best educational program, bar none, AMA, CMA, anybody else. We have more than 40 hours of CME that physicians can get on an annual basis just by attending our convention. And we're truly a magnificent organization. And we represent some of the premier doctors in the world. And we have striven with the Black Health Trust to bring many of these doctors and our affiliates to you every week to give you credible health information. So the NMA is our sister organization, and we promote their positions, and we wish you would too. Uh, a few, if you can show the slide, Simon. Okay, the cases on November the 22nd, there were 11,843,493 cases in the US. And at that time, we looked at the number of new deaths, and there were 253,600. Let's go to the next slide. As of the 20th, last week, there were 17,592,760 cases in the United States. As of today, the 27th, there are 18,730,806 cases, with new deaths being 329,592, and deaths over the past 24 hours are 1,692. Now, why do we show these statistics each time? Because it has been shown that Black Americans make up more than 2.8 times the normal death rate of all of the people in the United States. So this is very important to us to know that this is a decimating pandemic and it is real. I want to go to the next slide, Simon. I want to show the slide from the NMA that Dr. Leon McDougall showed a week ago. That, let's go to the slide of Dr. McDougall from the NMA. So the NMA created a task force, a vaccine task force, and the one right before this, well, I guess the one after that. And Dr. McDougall, who is the president of the NMA, who is a professor at the Ohio State University, he's the 121st president of the National Medical Association, appointed a task force of experts to review all of the data on the vaccines. They met with Pfizer, they met with Moderna, they met with the CDC, they met with the FDA, they met with the government task force, and they came up with a series of recommendations. We then looked at those recommendations.
Sorry, I couldn't quite hear you. Could you please repeat what you said?
We looked at those recommendations and we created our own task force to review the information of the NMA. That task force was chaired by Dr. Ivan Walks, who's a former commissioner, the commissioner of health for the city of Washington, D.C. And we convened a meeting on Wednesday past. And we had some 15 plus physicians on the line, and many of them in their own right experts in vaccine, psychiatry, internal medicine, pediatrics, infectious disease. And we discussed not only the NMA task force recommendations, but our own. And then we voted that we would endorse the NMA position on task force. And in summary, and we will publish this week, we voted that it would be good for the African American community in the United States, after consultation with their own physician or healthcare provider, to take and trust the vaccine, that it was safe, it was a matter of community safety. We will continue to review this every week. If our position alters or changes, we will bring it to you. But at this time, the group did in majority vote that we should publish that we're interested in following those guidelines. To be sure, there was a minority report. There are cautions, there are side effects, there are people who have allergies that should be cautious. That's why we encourage you to seek your information from your primary care physician provider. In case you don't have one, we have an affiliate company called Biometrics Second Opinion Expert, found at that website, biometrics.secondopinionexpert.com. And we have physicians who are culturally competent and sensitive to provide consultation to you as to whether you individually should take that uh, vaccine. And we offer that as a service. There will be no charge to you for that. And with that, I'd like to introduce our first speaker, who is Dr. Monique. And I wonder why her last name is Maxey. Is she related? Absolutely. And I'm proud of her. She is an intern. She's a recent graduate of medical school. And this may be her first professional talk. And I'm listening to her with great intent. Dr. Monique Hedgeman Maxey, the floor is yours.
Hello, everyone. I hope you can hear me. Thank you so much, Uncle Randy, for this opportunity. It's a real honor to be on this program. I think that it's a great opportunity for older and younger generations of Black physicians to come together with collective wisdom and experience to address the problems that impact the health of our community. And I intend to encourage more of my counterparts to join in on this program on a weekly basis. First, I would like to say, of course, I have no conflicts to disclose as an intern. I'm speaking solely on behalf of myself and not my institution, and I'm by no means an expert. A family medicine intern is a far cry from a pulmonary critical care specialist, but I will speak on what I've seen and what I've heard. And I also have a pretty bare bone style of presenting because I feel that a picture is worth 1,000 words. So I believe our administrator is going to pull up my slides. Thank you. Uh-oh. I might need to a little bit, it looks like the background on my presentation didn't carry over. There's a PDF that we could use instead, maybe.
Okay, do you want to project your own slides?
I can try that. Let's see. Okay, let's see if I can share my screen. One moment, please. Okay. Are you able to see my?
Yes.
Okay, hold on. Now I can't see it. Hold on one sec. Okay, well, I can't really see what you all are seeing, but hopefully it'll be clear enough.
The first slide is Tales from the ICU.
Yes, okay. So in this presentation, I'm going to talk a little bit about what it looks like to manage, first of all, what we're seeing out of LA County right now. And then secondly, what it looks like to manage patients in the ICU. And I'm going to touch briefly upon this debate, vaccine debate in Black communities that's happening around the country right now. So to start off this talk, I want to acknowledge and honor the memory of Dr. Susan Moore, who contracted COVID and was subject to racist medical treatment by her institution in Indiana. You know, I'm sure everyone has seen this, but watching this video was just heartbreaking, seeing the fear and sadness and disappointment on her face, which is kind of a grim reminder about the various forces that we have to overcome as a people in fighting this pandemic. As many of you have seen and are aware, Los Angeles is essentially the epicenter of COVID-19 in the United States right now. We are in the second wave, as was predicted. Essentially where New York was earlier this year, but arguably worse off at this point. I saw a statistic that suggested that 1 in 95 LA County residents is infectious with COVID at this time. Our ICUs are at 0% capacity. There's whole areas of the hospitals, including emergency departments and medical wards that are filled with intubated COVID patients. When I was rotating through the ICU, I saw instances where there were multiple members of one family that were intubated together on the same floor. And I've conferred with my colleagues that are working in other area hospitals, and they are equally, if not more so, inundated with code blues being called left and right. And it's a really kind of dystopian picture right now. Here's some graphical representation of the increase in cases and deaths and hospitalizations happening in LA County right now. So this is kind of breaks down what's happening by race and ethnic group. As you can see, our Latino brothers and sisters are really bearing the brunt of the second wave in terms of cases. This goes the same for hospitalizations. The green line represents the Black communities in Los Angeles, and the yellow line is the Latino community. Of note, these graphs were created before the Thanksgiving holiday, and so with Thanksgiving and Christmas, these graphs are going to get considerably worse, and it's just, there's really no end in sight at this moment. In terms of why our Latino brothers and sisters are being hit the hardest, there's a number of reasons for that. Many of them live in very densely populated and or impoverished neighborhoods. Many of them are living in multi-generational homes out of economic necessity, and are essential workers that have higher levels of exposure. And here's a representation of these numbers in table format. Again, as you can see, Hispanic and Latino communities are being hit the hardest, but unfortunately, we as Black people are not far behind. And so I bring this up because, you know, I see a lot of people out here not wearing masks, not socially distancing, really believing that it's not going to happen to them and it's not going to happen to their family, assuming that they'll be one of the lucky ones that is asymptomatic or has very mild disease. But people aren't really thinking about what happens if they or their loved one ends up being one of the unlucky people that has this terrible systemic response that leads to hospitalization, which is why I wanted to give a little bit of insight into what happens once you come into the hospital. So just in terms of my position as an intern, in the mornings, we round on all of our patients, and we as interns have to present each patient in terms of what happened to the patient in the last 24 hours, what adjustments were made to their medications and other treatments, and what the plan will be for the day to address their problems. And there's always a problem number one in our presentation. And currently that problem is always, almost always, acute hypoxic respiratory failure secondary to COVID pneumonia. And this is a typical chest x-ray that we might see in one of these patients. A diagnosis that goes hand in hand with this diagnosis is acute respiratory distress syndrome, basically where the lungs are so weakened by overwhelming inflammation that causes the alveoli or the air sacs in the lungs to collapse. So the typical story that I'm hearing is that a patient will have been exposed to COVID through a family member or someone living in their home. They initially have mild symptoms and eventually becomes more and more difficult for them to breathe, which brings them into the emergency department. They're discovered to have very low levels of oxygen. And so at that point, we do everything we can to avoid intubation. Early in the pandemic, we were intubating people fairly quickly, but we have changed our standard to the point where we really try to avoid intubation for as long as possible. So we do our best to manage patients with high flow nasal cannula, CPAP and BiPAP, having them self-prone, whatever we can to avoid intubation for as long as possible. But at some point, oftentimes these patients are no longer able to maintain sufficient oxygen saturation on their own. They start to use accessory muscles to breathe, which can eventually tire out. And at that point, intubation is indicated. And so it is very uncomfortable for people to have this endotracheal tube down their throat. So we use a variety of medications to allow a person to tolerate that. Some of the sedating medications we use include Versed and propofol. We use pain control agents such as fentanyl. We've even had to use some sedating antipsychotic medications such as Seroquel and paralytic medications such as Nimbex in order to keep patients stable enough to maintain the tube in their throat. And we have a very established protocol called ARDSNet, which was developed by the National Institute of Health and the National Heart, Lung, and Blood Institute to develop a series of protocols that allow us to adjust the ventilator as needed, as is indicated by a patient's needs. So there's three main things that we look at as we are adjusting the ventilator. We look at the respiratory rate, which is how often the machine is taking a breath, the tidal volume, which is the amount of air that is delivered with each breath, and the PEEP, which stands for positive end expiratory pressure, which allows the alveoli, sacs in the lungs, to resist collapse. The FiO2 is the fraction of inspired oxygen that we're delivering to the patient. Natural air has FiO2 of 21%, and many of these patients are requiring 100% FiO2. And as you all are aware, we are still doing proning in the ICU, where basically we place a patient on their stomach. It allows for better aeration of the lungs. And this can be a pretty involved process where multiple people have to come into the room to turn a patient over. But we're still having enough evidence to suggest that proning is beneficial to these patients. I think that one of the most important parts and most delicate aspects of ICU care are goals of care discussions. And the point of these discussions, they start really at the very beginning. Once a patient is intubated, if someone's been intubated for like a week or two and they're not showing any appreciable improvement, if we're doing spontaneous breathing trials every morning and they're not able to show that they can maintain their airway on their own, if they're having multiple complications or evidence of organ failure, at that point, it's time to engage the family about next steps. This is a much easier process when the patients have advanced directives in place, which is something that can be done with any primary care physician, where you basically determine what you would and would not want in terms of care if you were unable to speak on your own behalf. Unfortunately, most people do not have advanced directives, and we're generally speaking with the spouses, the siblings, or the children of these patients. In these discussions, we really try to find out, who is this person? What would they have, if they could speak for themselves right now, what would they want for their care? What kind of quality of life would this person have, even if they were to achieve a full recovery? Oftentimes, this is a very difficult conversation for families to have. It's very difficult for people to accept the idea that their family member may not make it out of this. And we oftentimes will call upon our palliative care colleagues to assist us in these discussions. The key point that I want people to understand is that these patients are dying alone. They cannot have visitors in the room. Family members are not allowed to be at bedside with them. And then particularly with the surge, the visitation policies have become even more restrictive. And so, our nurses and other staff are doing everything that they can to give of themselves and be there for these patients, and have been able to arrange video calls and the like. But it is indeed a very lonely death. I also just wanted to share that rotating through the ICU, I delivered chest compressions for the first time to a Black COVID patient. And it was the first time that I'd done it. It is a feeling that I can't really put into words what it feels like to give all of your strength and might to try to save a person's life, oftentimes in vain. It's one that can't really be encompassed in words. And it is an experience that I was thinking of when I received the COVID-19 vaccine last week on Wednesday. I received the Pfizer vaccine, and afterwards and leading up to getting the vaccine, I had gotten a lot of inquiries from some of my friends asking questions about it. And so I decided to post this picture on my social media in solidarity with the vaccine campaign. One of my friends messaged me and asked me, "Hey, how are you doing? How's it going? Is everything okay?" And I said, "I'm fine. I feel perfectly fine. My arm is a little bit sore and that's all." And he said, "Well, I wasn't going to take it because of what Farrakhan was saying, but I will take your expert opinion." And so I had to go back and find out what exactly he was talking about and what Mr. Farrakhan was saying about this vaccine. And, he said a lot of different things. He said that the vaccine is toxic waste. He said it's part of the death plan. And I'm going to quote Mr. Farrakhan when he said, "We are so frightened over this COVID. Now they're getting us ready for the vaccine. Brothers and sisters, do you believe in Satan? You trust him. After all he has done to destroy us, you trust him. And your trust is sickening because you love your enemy and you hate yourself. How could you allow him to stick a needle into you saying he's helping you?" Well, I want to respond to that, and I'm going to hit him with the Obama, "Let me be clear. I am a God-fearing woman. I love myself and I love my people. And that is why I have taken this vaccine, and I encourage my people to do the same." At this time, I want to give a shout out to 2 Black women in medicine that are joining this fight against COVID-19 in our communities. The first is Dr. Gina Guillaume, who is a community medicine fellow in the family medicine department with me at Harbor. And the second is LaShira Lash Nolan, who's a second-year medical student and student council president at Harvard Medical School. They were recently featured on a panel with Black Lives Matter LA, which I encourage everyone to watch on Facebook if possible, because I feel like it really encompasses this debate that's happening in our community right now. They were on the panel with this gentleman, Mr. Riza Islam, who was expressing views firmly against vaccination. And unfortunately, much of the information that he was sharing was categorically and demonstrably false. And this is really important because he has a very large following. And so, I contend that there's a lot of misinformation and mixed messaging that's confounded our ability to wage effective campaigns against this pandemic. And also, I acknowledge the fact that there is good reason for us to feel distrustful in our community. But I will say directly to Mr. Farrakhan, Mr. Islam, and others that are spreading this rhetoric, I will caution you to think carefully and critically about the potential consequences that your words may have on our community, because it is this type of rhetoric that will get more of us killed and can lead to more Black deaths that could have potentially been avoided otherwise. In closing, I want to acknowledge the tremendous effort on behalf of the healthcare personnel across the city that are meeting the demands of the surge. Across hospitals, there's multiple departments that are deploying special COVID ICU teams, including surgery, anesthesia, and even pediatrics. It's amazing to see these different departments coming together and collaborating in ways that they have not previously done so. And it is just a tremendous honor to serve alongside these people, the attendings, residents, nurses, therapists, techs, and others that are just bravely doing their jobs every day, putting themselves in harm's way. I've learned so much from them. I'm grateful for them. I still maintain that it is an absolute privilege to do this work. And I'm happy that we have this vaccine that can allow my colleagues and I to deliver care to our patients without living in fear for ourselves or our own loved ones. I encourage everyone to keep wearing their masks, distancing themselves, doing their best to eat well, exercise, and get proper nutrition to support their immune systems, and to get vaccinated once they are able. Thank you.
Thank you so much, Dr. Maxey. I appreciate that. And I'm going to give you the honorary title of professor. Uh, Dr. Barbara Neighbor Stevens, would you lead off any questions in the chat box for
Yes.
Dr.
First, let me say how well you addressed the question and how appreciative many of us are. There are multiple comments in the chat box regarding your candor. There was a question though, and I hope you can see your slides now. There was a question really asking for clarification on, and let me read it to you to make sure. Cases versus deaths. Are Hispanic cases higher, but Black deaths higher? If that is so, why?
No, the cases are cases for Hispanic and Latino communities and cases for Black communities are both disproportionately high. I would say, and that is the same for the deaths as well. I would say that at this time, both the cases and deaths are higher in the Latino community. We don't fully understand all of the reasons why that is, but again, I think that part of it just has to do with the economic circumstances, the environmental circumstances, and the occupational circumstances that these communities find themselves in. I also just wanted to acknowledge my colleague, Dr. Mohammed Shuaib, who assisted me greatly in putting this talk together. But just kind of getting back to your question, yes, I think that it is disproportionate in both communities.
Thank you.
May I ask a technical question? Has anybody assessed the vitamin D levels and other levels of things like CRP and homocysteine in patients who are admitted both to the hospital and to the ICU with COVID?
Yeah, I'm sure that research is ongoing. I have seen some articles to suggest that the majority of, or at least 50%, or if not a majority of hospitalized and or intubated COVID patients are vitamin D deficient. You know, it's interesting. It's not clear whether or not that is the vitamin D deficiency is a direct cause of people being more susceptible to the virus or not, or if that is an association that has been found. But I think that it definitely behooves us to make sure that people are supplementing their vitamin D and their zinc and other vitamins and minerals that will boost the immune system. And as we know, we as Black people have vitamin D deficiency is a major issue in our community.
I have a question for you that you're certainly in the position to answer. So as you and your colleagues at all the different levels of the healthcare teams in your institution continue to render service, what have you observed to be the biggest thing taking a toll on the healthcare workers? Because, and the reason I'm asking is there's so much discussion in the news about burnout and the impact of dealing with this disease over such a long period of time and the toll that it's taking on the individual healthcare providers and their families. I was wondering if you could comment on that.
Um, I think it's really multifactorial. On one hand, you have providers that are just working crazy hours with not a lot of rest, who, up until we had this vaccine, were having to go and provide direct care to patients, many of whom were getting sick themselves, and risking bringing the virus home to their own families. In trying to avoid doing that, having to get hotel rooms or find other accommodations so that they can protect their own loved ones. Fortunately, at Harbor, we have decent amounts of PPE. That doesn't really seem to be an issue that we're struggling with, but there are other institutions that are still having PPE shortages, and that is an additional stressor. But I think what really is hard, and that's why I highlighted the goals of care discussions. It is very difficult to have these discussions with families that are not able to be there in person to advocate for their family members, and to see these patients, just kind of slowly deteriorating with no one there with them, you trying to be there for them as much as possible. And just seeing just continuous constant death, and then not having time to find outlets for that stress and that trauma. People probably don't even have time to see or find a therapist to process some of these very traumatic things that they're experiencing because they have to go to work. And so the whole experience, everything about it is traumatizing for everyone. You're being pushed to your limits as a professional. You're being pushed to your limits as an empathic, emotional human being. And it's just tough for everyone involved.
Well, I thank you so much, Dr. Maxey. I want to make sure that all of our attendees know that the chat room is for questions that we have for the speakers, and we're asking each person to limit themselves to 2 questions per speaker, so we don't just fill up the chat room with personal views. If you would please honor that, that would be very helpful. One other question I have, Dr. Maxey, and that is, we know that from research that I've done, that people who are the lower socioeconomic level tend to have more uh, pre-existing conditions and more illness related to racial composition. But I worked for 7 years as a medical director of a group called the Executive Leadership Council, which consists of the top African American executives who were either CEOs, chairs of board, senior vice presidents of Fortune 500 companies. And we kept records on them for 7 years doing health screenings. There was no difference in their health statistics from the worst communities in the country of African Americans and these high priced, high placed brothers and sisters in corporate America. Would you comment on how that could be so?
I'm sorry, I didn't hear the.
The question is, uh, I've seen data and collected data to show that there's no difference in health statistics and health outcomes in the highest socioeconomic group of African American executives and in the worst communities of poverty and color in the United States. It transcends socioeconomics.
I mean, unfortunately, um, there's a lot of different reasons for that. I mean, you look at the rates of diabetes and hypertension and other conditions that are making people more vulnerable to serious outcomes of COVID-19. And these are the types of conditions that are affecting Black people of all socioeconomic backgrounds. Um, it's interesting that not only are we talking about these chronic conditions, you're talking about the effects of racial stress, the weathering hypothesis um, on our ability to withstand insult. And there's no way that we can at all downplay the effect of racial stress on our ability to withstand this type of insult. Um, so I think that is a big part of why there's no difference in our community. And then you can even start to get into the discussion of epigenetics and the fact that we carry the trauma of our ancestors in our genetic code. So it gets really deep in terms of why we're so uniquely impacted by this disease.
Well, thank you so much. I think if I remember some of our previous lectures, the allostatic load and the adverse childhood events play a role in all of us. Dr. Neighbor Stevens, are there any other questions for our speaker at this time?
Not for our speaker. I think we're ready to move on to our next speaker.
Thank you so much, Dr. Maxey. Appreciate your presentation. Stick around for more questions.
Thank you.
Our next speaker is Dr. Rhonda Moore Johnson. Dr. Johnson, would you please take the stage?
Okay, can you hear me now? It was saying I was muted.
Yes.
Okay, first of all, while my slides are being displayed, I want to say thank you to the leadership of Black Health Trust for asking me to join you today. And I want to give a special shout out to Dr. Helen Davis, who I believe is one of your colleagues that reached out to me to ask me to give this talk today. So if I could have my slides up, thank you. And I won't be sharing my screen. You can share. My story is a story that I would have never anticipated that I would be telling you today. I just want to just start off this way. And I'm going to be talking about two types of outreach. One is an individual, it's a personal outreach that I have been involved in personally, and a collective strategy that I've coordinated through the Gateway Medical Society, our local component society of the National Medical Association. But I want you to just take a look at this picture of the city of Pittsburgh. Some of you all may not be familiar with Pittsburgh, Pennsylvania. It is a city in southwestern Pennsylvania. It is the second largest city in the state of Pennsylvania, second only to Philadelphia, that great city of brotherly love, as it's called. It has a long history of industry. Nicknames for this city are the Steel City. It is also called a city of bridges because we have around somewhere between 450 to 500 bridges that span the various rivers. You are looking at the point, what we call the point, which is the confluence of two rivers, the Allegheny and the Monongahela, and they come to form the Ohio River, which eventually joins the Mississippi River and flows down to the Gulf of Mexico. Pittsburgh is Next slide, please. Interesting city. It's a tale of two cities, and this is what I'm going to be talking about today. Our population is formally around 300,000 within the city of Pittsburgh. If you want to extend that to the surrounding communities, you're talking about a greater Pittsburgh region of about 2.3, 2.4 million people. And I grew up, it's a city where I was born. It's a city where I went away, like many Pittsburghers, but came back to when after I completed my educational training. There's something about Pittsburgh that draws us natives back. It's where some of us have roots that are deep. I would say my roots are very deep in Pittsburgh. So we're going to go through some facts about Blacks in the city of Pittsburgh and how this impacted COVID. Tell you some things that I've been doing, tell you some things about the Gateway Medical Society, show you some selected outcomes, and then we'll take questions and answers. Next slide. So Pittsburgh, it's been interesting. It has ranked as one of the most livable cities in America repeatedly for many years, starting in 2005, 2011, 2009, 2012, 2014. It has been ranked among either the first or the second most livable city in America. And some people call it the Paris of Appalachia because it's surrounded by the Appalachian Mountains. Yet 1/3 of our Black residents, that includes my family, includes my entire family history growing up in Pittsburgh, live in poverty. And one of the famous artists that have come out of Pittsburgh is August Wilson. And he depicted the struggle of Blacks in Pittsburgh in many of his plays. And he said, Pittsburgh is a very hard city, especially if you're Black. And I will definitely agree with that. Next slide. There's longstanding inequality. One of the speakers that follows Dr. Stephen Thomas, I had the great pleasure of when he was in Pittsburgh, collaborating with him on some of his initiatives when he was at the School of Public Health here. But Pittsburgh, people are surprised to hear these statistics. So I'm just going to go over some of these because we understand, like Dr. Maxey said, it's these social determinants of health that is having this adverse impact in terms of COVID-19 cases and deaths. And so Pittsburgh is just one example of that. For every dollar that Black women earn, they earn 54 cents to every dollar compared to white women in Pittsburgh, and 70 cents to every dollar that Black men earn to every dollar that white men earn. Black women's poverty in Pittsburgh is higher than 85% of other comparable cities. And this data comes out of a University of Pittsburgh Gender, Race, and Equality and Inequality report that was released in September 2019. The top 5 occupations for Black men are essential, basically those in the essential and industries, maintenance workers, firefighters, factory workers, food service, and construction. The top 5 occupations for Black women in Pittsburgh are healthcare support, nurses, aides, medical assistants, personal care that go into the homes, office administrators. That's another, I call it glorified word for what used to be called administrative assistants or secretarial support, maintenance, housekeeping in particular, and working in factories. And a lot of that is now retail based. Next slide. In terms of our health comes, this city has long-standing health disparities. Health disparities continue to be a major problem for African Americans in Pittsburgh. We have very high rates of maternal mortality. Our babies are 3 times more likely to be born with low birth weight. Our men face higher rates of homicide, cancer, cardiovascular disease. And nearly 6 out of every 1,000 Black men in Pittsburgh die of cardiovascular disease each year. And very similar statistics for Black women. And cancer is the leading cause of death. And I know this slide is hard to see, and I just wanted to take a second to explain that term, AMLON. If you're not familiar with it, it's Asians, multiracial, Latinx, other, and Native Americans. Pittsburgh is pretty much a city of Black, white, and Asian, with Blacks being around 27% of the population of Pittsburgh, 27 to 30%. Next slide. So here we come with COVID back in March. And as I said, this is part of my personal story. And I'm active on Facebook. I learn and social media, Instagram. I learned years ago, I'm a mother of 3 children. And if I really wanted to know what was going on with my children, I had to adopt being on social media. And I'm able to kind of keep up with them a little bit. They're all grown and have their lives. Most 2 out of 3 live away in different cities. So I became active on social medias many years ago. And so when the pandemic came and hit, I was seeing all these posts around how Black people weren't going to get COVID. Remember back in March or so, Black people didn't believe that we were going to get COVID. And there was just an enormous amount of misinformation. And because I had spent so much of my life practicing when I was in clinical practice as a pediatrician with vulnerable populations, and because I'm so aware of the health disparities that exist nationally and locally, I knew, and I know that demographics and the socio-demographics of Pittsburgh and the over-reliance of public transportation, longstanding racial segregation in communities here, I just knew that wasn't going to be the case. And so I started reaching out on social media. And I don't have any media skills. I want to just say this because what my take-home message that I want to repeat over and over, there are 35 million Black people here in the United States. I love that Dr. Maxey pointed out the so much misinformation that our folks are listening to actively and getting all of this misinformation. And so I just literally picked up my phone one day and started recording videos. And then people started, saying to me, oh, this is so helpful. Will you make this public? Will you share? And so I actually have developed quite a following. And I literally have been doing these videos, I would say at least 4 days out of a week since March. I once said, okay, surely there's not going to be enough to talk about with COVID. There is never a lack of things to talk about with COVID. And our people need information. And, they are shared so publicly. And because of some missionary work that I have done, not only, and they follow me, but not only is it followed and distributed nationally, California and all over the United States, this information is shared in 4 or 5 different countries, Haiti, Kenya, and I'm being told this. And I don't see any of this, once you give this information out, it's out there. But, I comb the medical literature and I have one intent, and I say this all the time. It's not to keep you from engaging with your doctor. It is to provide information in a way that the community can understand it. And I read the medical literature, I keep up with what's on television and the news, and I try to get all the information from the underground. So people now send me, I'm all aware of what Minister Farrakhan and Lizzo is saying and some other sources, because people send me all of this. Dr. Johnson, what do you think about this? So it helps me know what's going on in the alternate, I call it in the alternate community, that folks are paying attention to, because a lot of our people aren't watching mainstream television. They are not watching the evening news. They are not watching CNN. They're not watching Fox for sure, and so where do they get their sources from? They get their sources from Instagram, Snapchat, YouTube, and all kind of places that we don't typically think of in terms of reliable sources of information. So sometime in September, I had so much information out there. People were asking me, well, what day was that you talked about this? Well, can you send me that information again? And again, just about what I've talked about is just everything. I learned from part of my work. At one point, I supported sales in my organization, my former organization. And our salespeople taught me you have to call on a client sometimes up to 25 times. And also, I supported our advertising department, and they said you have to repeat something a minimum of 20 times. So I've learned that you have to repeat these messages over and over again. And I've been very creative. So I may call COVID, um, you know, the virus that is you're the meal ticket, or a thief, or you need to have a surge protection plan in place. I try to use language that will get somebody's attention and repeat the same message in different ways. And people tell me over and over, repeat it, say something different, but do it and say it again. So I've again, this is my own personal story. I can only tell you, and I encourage all of us to pick up whatever it is we have access to and start talking to our people. You don't have to be trained. You don't have to have media skills. You just need to do it. And folks will be listening and learning from you, and they will be grateful. Next slide. Now, at the same time, I'm active in our Gateway Medical Society, which is our local NMA component society. And I've been on the leadership team for many years, have served in various capacities. And currently my role is I've been the fundraising chair. And so because I've have a long history of working with philanthropy, I have been reviewer of grants. I know how to write grants. So I wrote some grants to help our organization, and we were funded to do COVID-19 outreach. And one of our, I'll call it sizable grants because it was for around $30,000, was from the Heinz Endowment, which is a local philanthropy organization. And it was to do COVID awareness and outreach. So we put together a campaign, and I just wanted to give a shout out to the leadership of the Gateway Medical Society, who has been all in, all hands on deck. This has been a collaborative effort with the entire Gateway Medical Society. You can see there our mission, our gap, our goals are to close the gap on healthcare disparities. That pretty much sums it up. We are a small, I'd call us a small organization, all volunteer, multi-specialties, multiple affiliations, because healthcare in Pittsburgh is very polarized between two different major institutions, but we collaborate and we work together for our communities. So next slide, if you will. So again, being active in social media, and you can see there, that's our educational campaign goals. And we had a number of strategies. One was to work with our partners, which were our organizations that we collaborate with a lot, the Black nurses. So we collaborate with the Black nurses and they participate a lot in our community outreach. We also have ties to the church community. Pittsburgh is lucky. We have a collaboration of churches that I helped organize called the Faith-Based Health Collaborative. There are over 60 churches, and they come together and they work around doing health messaging to their congregations. And so we worked with them. We asked them I developed a needs assessment survey and asked them what their needs were. And we had a series of 4 educational sessions with the churches. Next slide. And community organizations. So we've reached out. So again, and our strategy has include the health infographics, simplification. repeated, simplified messaging, ongoing virtual webinars. Again, mostly all of this outreach has been virtual. We've had panel discussions, which I'll go into a little bit more. We partnered with a non-traditional source. I felt that we needed to not be preaching to our choir. We needed to be preaching to parts of the community that are harder to reach. And so we developed this wonderful partnership with a community activism agency, One Hood Media, and I'll talk a little bit more about that. I talked about the direct engagement, speaking engagements, and again, we've done so much outreach to the community on COVID, and we're seen as a trusted source of information on COVID in the greater Pittsburgh area. Next slide. People have said to the Gateway Medical Society, we didn't know this community had so many Black doctors. So one of the affiliations that I'm really excited about has been our collaboration with an activist organization called One Hood Media. And their mission is to build liberated communities through art, education, and social justice. They do, as Dr. Thomas said, they are very, I'll call them disruptive. In fact, they just got an award for, it doesn't display right, but for Pittsburgh People Activism of the Year. And we've worked with their co-founder and CEO, Jasiri X, to host a lot of virtual education. And that was a new partnership. It was, we're partnering with rappers and community activists. And, it gave us an entirely different entrance to a different audience that we historically as Black physicians may not have been able to reach, but they have a huge following in Pittsburgh. And it was good for them to partner with us. It's been extremely beneficial to our medical society and to the community. Next slide. So I mentioned that we do a lot of infographics and we post them on Snapchat, Instagram, Facebook, and we share them with a lot of community organizations. So they incorporate them on our website. And we try to have culturally tailored, simplified information. And it's not just about COVID, it's about the flu, it's about staying connected to your primary care doctor. It's about making sure you're getting ongoing care for your chronic conditions, such as your colon cancer screening, your breast cancer screening, managing your hypertension, managing your diabetes. And we just plaster, I call it our social media sites, with this information constantly, repeatedly, over and over and over again. And it gets shared. And social media gives you all of these, what are called engagement statistics. So you can see where your opportunities are in terms of spreading your information. Next slide. So I'd like to just share, again, this is just my little personal, I call it service. I'm a missionary, and I've, as I said, led missions in 4 or 5 different countries. And so I had just come from Kenya, a 2-week mission in Kenya at the end of February, and came back and COVID, broke out in March. And I just said, this is just going to be an extension of this mission work that I do. So, again, these are just for the last 3 months. What I have found is that, and I don't have the statistics to share with you because I just pulled this together very quickly once I was asked to give this talk. But what I have found, I'll just tell you anecdotal, but I have the data to support it, is that, COVID fatigue is real. And people aren't listening as much as they used to. And, people are just tired of COVID. They're just sick of it. And people don't want to hear about it, but we have to keep talking. We have to keep using our voice, regardless if they want to hear about it, because we see what's happening with the cases are just going up exponentially. So again, as I mentioned, in September, I had so much content, I decided to create a YouTube channel, which is something I would have never done before. And just to serve as a library for this content. And YouTube gives you a whole lot of information. I don't have that many subscribers. Facebook and Instagram have been a much better way to get communication out for me. But again, I have this account so I can know what I'm doing there. And I am committed. As soon as this pandemic is over, I will put these, I'm putting this down. This is not something I want to do for the rest of my life, but I just doing it now because it's helping. Okay, next slide. And then lastly, I'm getting close to the end here. Next slide, some metrics. Again, I know these are hard to see. We've had these Ask a Black Doctor segments with Jasiri X and One Hood Media. And those, as I said, again, we didn't have these followers. He had all these followers. You can see 29,000 views, 23,000 views. And again, this substantiates that. And we've talked about a number of things. We've talked about cancer care. We've talked about breast cancer. We've had cancer experts from colon, breast. We've had mental health experts. We've had a lot of our younger resident physicians to reach out and talk to young people. One popular segment was on sex and COVID. We had a lot of viewership around that topic, and I'm not going to go into the type of questions that were asked. But again, you can see the viewership has declined as the pandemic has persisted. But we continue forward. And next year, we were doing these bi-weekly. In 2020. We're going to go to once a month. And it'll be a little easier for us to man that, because again, all of our doctors volunteer. We also had engaged our Latino physicians around Hispanic Heritage Month. And again, it's been a very good collaboration. Next slide. So again, I'm just sharing some information about the infographics. Again, using multiple avenues to reach. We hoped going forward to have some young people doing more on Snapchat. So that is our plan for the future. We were able, with our grant funding, to actually hire a young professional African-American woman who wants to become a doctor. So we're actually mentoring her along this journey as she's doing some of this social media outreach for us. And I think that's it. Let's see. I think that's it. Yes. So disclosures, I don't have any. I don't, and my views are my own.
Thank you, Dr. Rhonda Johnson. I certainly appreciate your presentation. It was thoughtful. And based upon this, I hope you join us on our advisory at the Black Health Trust. We can use your input and expertise. And I thank Dr. Helen Davis for bringing you to us. Dr. Barbara Neighbor-Stevens, are there any questions for her in the chat box or from you?
Well, first, I'd like to congratulate you, Dr. Johnson and Gateway, for the absolutely fantastic job that you're doing in reaching the community. I had a question that I wanted to ask you. As you developed your relationship with One Hood or iHood, I forget now what.
One Hood Media.
One Hood,
Yes.
One Hood Media.
Mm-hmm.
What did you all discover to be your biggest obstacles for reaching the community? And then there's some questions I'll share with you from the chat.
Okay. There were really no obstacles. They are a group of activists. So they are everywhere in Pittsburgh, everywhere, every protest. I mean, this whole thing, with all these protests, and we were able to help guide them in terms of keeping people safe during all these protests that happened after George Floyd's death in Pittsburgh. So there were really no obstacles. And when we made this decision to partner with One Hood Media, I simply said, this is what we're going to do. We're going to do something different. My whole point is we cannot keep using the same channels because otherwise we're going to get to the same results. We need to meet people where they are. And, you know, people who are artists and in the community, the rappers and the activists, they know people will listen to them sometimes more than they might listen to us. You know, a revelation of mine has been is that, you know, we like to think that as African American physicians that our community is automatically going to embrace us. Well, the truth is we have to build trust as well. Trust is earned in our community. It, it's not automatically assumed or given. So by partnering with people who already have what I'll call street credibility, it will help us get information out that our people desperately need. So there were no barriers whatsoever, none. It's been a great partnership.
I am I'm so happy that we have the next speaker that will be coming on in a little bit because his focus is all about building trust. And a number of the comments in the chat have been around the issue of trust and the lack thereof in the Black community and how can it be built and why should and how should the Black community accept the information that they're hearing about vaccines, which is certainly what Black Health Trust has been all about. I think that I want to reserve the response to those comments until after our third speaker, because I think all three of our speakers are hitting on some critical points that are troubling our community and potentially very detrimental to our community. But at this time, I'm sure it is time for Mr. Brooks to come on. Mr. Brooks, are you ready?
Hello there. The program today has been outstanding. I mean, it's just so much information that's being provided. And me and my family have done a Zoom meeting for Christmas. First time ever to do a Zoom meeting. We were always in each other's faces, visiting Philadelphia and doing it. But there were like 40 family members that did a Zoom conference, and we were talking about what happened this year, what we're grateful for, and it was just fascinating. And when I was thinking about all the stuff that's been done around Black Health Trust, Randall's been a brother of mine for a lot of years. And we've done work at ELC together. We've done work on this. And the remarkable journey that this thing has taken off on, and I love the presentation by Dr. Johnson. She created something out of nothing and she's found a lot of the same results that we found over, the last 6 months. And it's outstanding. And I think that the big thing for us with Black Health Trust, there doesn't need to be just one organization or one person that provides the information. We got to be smart enough to partner with others and expand it that way and drop our egos of being the only anything and let others help us so that we can take this to the next level. So I love the presentation by Dr. Johnson and Dr. Maxey earlier than that. We had some amazing success. After Randall's original vision and asking others to help, when you look at it 6 months later, we're now partnering with the National Medical Association on the vaccine distribution program. And as a master's degree, former CEO of 2 Fortune 500 companies, it's fascinating for us to be able to work so closely with other organizations. This NMA relationship is going to flower and take it off to another direction. And it was great to see the talented doctors with all kinds of backgrounds working together in a very supportive way. It's a friendly conversation. It's only going to get better with time. We're working on stuff with our website and the way in which we approach. And Dr. Johnson couldn't be more right. Young people will create better technologies and better ways to communicate. And we got to take advantage of their expertise. And We're going to have a new website at Black Health Trust around the second week in January that's going to take it to a whole nother level. It's going to be easily accessible, and we're going to be able to use it to move forward. We're making great progress on working with companies to fund us and help us get started. We got to go beyond food, working on the shoestring to get things done with the steering committee members contributing monies and fewer donations from our viewers. We need our viewers to step up and support this program, or we're not going to be able to maintain the quality of the program. We need everybody contributing what they can contribute so that we can take this to the next level. So in ending, just a couple thoughts. We need voters to come out in Georgia and vote. We need those two elections, two senatorial elections. We need support to make sure that the right things happen in that election. So we need you to come out in record numbers as you've done in the past. And we need you to take the time to look at our website, our existing website, and then our new website, and look at blackhealthtrust.org and contribute. We're not even giving minimum requirements or minimum amounts. Anything that you can do to help us is going to help us stay steady. We love the organization. This has become a family organization, and we love it. And we need your support to take it to the next level. Thank you guys very much. And everybody have a great new year and be safe.
Thank you, Mr. Brooks. We appreciate you. I want to speak about the disclaimers that even though we're a group that consists of a lot of physicians, we are not giving you medical information to follow directly, but rather we encourage you and insist that you go directly to your own personal health provider to get your personal advice. Now, if he says something different than us, come back to us and we'll advise you again. But we want to make sure that the information that we give here are recommendations for you to discuss your personal care with your own personal physician. That should be very clear. And I appreciate the speakers so far. And we have been treated for the past few months to some of the best topics and best speakers there are. You know, in addition to the several thousand people that we call lay people that make up the majority of our listening and viewership, we consistently have 20 or 30 nationally known physicians on the line with us, listening to everything and contributing. And we also have a medical advisory committee that meets every other Wednesday. And we have some humdinger, knock down, drag them out discussions about what we're going to present that represents credible information on our Sunday meetings. And we invite all of our healthcare listeners to join us and join our advisory committee, and we're going to expand that. We also have sent invitations out to providers to join the biometric second opinion expert, and that will help you be a consultant to many in our community who don't have their own primary care doctors. And we have excellent doctors in the group. We invite you to apply to join us. Dr. Nabert, would you introduce our next speaker?
Well, bring us on to the end of our program is Dr. Stephen Thomas, who, as I mentioned to you before, is the chief principal investigator and lead at the Center of Excellence on Race and Inequality at NIMHD. And without further ado, I would like to welcome Dr. Thomas.
Thank you very much, Dr. Stevens. Can you hear me okay?
We can.
Okay, very good. What an honor to be here. It's Sunday afternoon and we are here on Zoom. Amazing. One of the silver linings behind all this is that we've learned how to use this technology. Anybody who was like on the fence, Dr. Johnson, you're in the deep end now, aren't you? And I think we can use this to our advantage. I really want to thank Dr. Maxey for bringing a public health person in the room. I can't write a prescription, Dr. Hedman Maxey, but I can help your patients once you discharge them to live a better life, to follow your discharge orders, and to make sure that their neighborhoods are safe places by addressing those social determinants of health, through legislation and other kinds of policy. So COVID has brought us together, and I don't think there is an after. I think it's preparing for the next wave, the next coronavirus, that the infrastructure we're building now should stay in place and grow. We're filling a gap, and that gap should not be abandoned after the immediate crisis has passed. I'm going to take a chance here and ask the organizers to allow me to share my screen. And I want you all to cross your fingers out there, because you know what happens in these Zoom. We all been to Zooms from Hades, right? And Dr. Stevens, can you see my screen? Just give me a verbal yes. Okay, very good. Thank you very much. So first of all, whoever you, Dr. Maxey, whoever you got handling the graphics these days is awesome. I love the way you put out the flyer.
I wish you'd worn your hat. I like that hat.
Well, you know, they call me the Hat Man, and as you can see, Dr. Maxey, I'm growing something under here because since March, I said I will not get a shave until everyday Black people get access to the vaccine. And who knows, I might be looking like a Black Santa Claus before all this is over. But at any rate, it reminds me that these are unusual times. These are unusual times. And so I'm just going to take a moment and hopefully set the stage for what I hope will be a robust conversation. I think that our answer has been laid out by our ancestors. Our way forward has been laid out by Dr. King, the other civil rights leaders, and let us not forget that dream. And let us also not assume we're going to agree on everything. But can we disagree without being disagreeable to one another? And Dr. Johnson, I learned a lot in Pittsburgh. The 10 years I was there as the Philip Allen Professor of Community Health and Social Justice, we launched some of the most innovative programs in the United States, had their origins right there in Pittsburgh. And some of what I'm going to share with this audience today comes from that experience. Just as a way of background, this is our homepage. These are the webinars that we have coming up on January 12th, talking with patients and communities about COVID vaccines, tips for effective communication. And then on January 19th, listening to community voices, addressing questions and concerns about COVID-19 vaccines. As Dr. Johnson knows, I like to bring people who control the system together in the same room with people who have lost all hope in the system. And through that kind of mix, we come up with innovative solutions. On the right, you'll see the webinars that we have already conducted. They are archived. And I would like to make an offer to the Black Health Trust to think of the University of Maryland School of Public Health, Center for Health Equity in College Park, Maryland, as your academic arm, as your public health, academic health equity arm of your organization. We are there for you, and we're training the next generation of scholars who will take over from us. So we've seen a lot of statistics. Maybe you've seen this one. And this one is interesting. You can put whatever label you want on what's circled here. You see the United Kingdom, Canada, France, Australia, Italy. Whether you say it's socialized medicine or single payer, it really doesn't matter. What's this story telling us? What's this graph telling us? Look at the United States, for-profit care. My point here is that we are not following what works, and other countries are. And we can have a whole discussion as to why, but let there be no doubt, people are dying and suffering needlessly, and there must be accountability. And I think the Black Health Trust is a group that can help apply accountability. Now, again, things change so fast. We're now over 300,000 dead. 3,000 a day infected. And as Dr. Johnson and the young Dr. Maxey mentioned, we've known through the health disparities that Black people were in the crosshairs of this pandemic. But it took the New York Times to file a lawsuit against the Centers for Disease Control just to get the data released by race. So these are unusual times when our leading health officials have to hire security. We see these things happen in other countries, not in the United States, definitely not in my lifetime. Maybe not in your lifetime either, Dr. Maxey. But I inserted this photo, which was a highlight of Dr. Fauci, because I wanted you to see who was over Dr. Fauci's shoulder. Dr. Maxey, who is that?
I can't identify from here.
Dr. Johnson, who's that Black man? She may be muted. That's Lou Sullivan. My point is, Dr. Fauci's been around long enough where he had a Black man as his boss. I think the other thing is that agencies like HHS, where Lou Sullivan was a former secretary under a Republican administration, or the Centers for Disease Control, where Dr. David Satcher was director under a Democratic administration, we typically, as Black people, when things go bad, don't march on those institutions. We don't pick at the CDC, we don't pick at HHS, because we've always assumed they're there to protect us. But look what happened in these 4 years. In these 4 years, we realized that we cannot take for granted that these institutions will protect us, because it's possible that they could literally be muzzled. And we witnessed that firsthand. I think we're going to have to save ourselves. We're going to have to create structures outside of the government that we control to save ourselves. Now, again, right out of the newspaper, you've all seen this. We've heard this for a long time. But look at the caption there on the left. I won't be used as a guinea pig. We've heard that. But I won't be used as a guinea pig for white people. Now it's racialized. And there is real concern that I'm hearing in the community that somehow, yeah, there's vaccine out there, but the vaccine that white people are getting is different than the vaccine Black people will get. We'll talk about that. That's all part of the misinformation, part of the myths that we have to unpack. But it's racialized and it's politicized. And that is new. And Dr. Johnson, you made me go back. You made me go back to bring out the work that you and I did together in Pittsburgh for a decade, where we launched the Healthy Black Family Project. And I think here again is an example of models at work, with support from local foundations and the National Institutes of Health. And we have examples of these things that work. And then as a grant cycle ends, or foundations move on to another flavor of the month or flavor of the whatever it might be in their strategic plan, these things just die. We know what works. We need to implement and value the ideas coming out of our own community. And for the young Dr. Maxey, thank you so much. As you were speaking, believe it or not, CNN was interviewing Dr. Kamara Jones and one of the other authors here, Dr. Joya Perry, on CNN about this very issue. And so say her name, Dr. Susan Moore. And I think that Dr. Maxey, as you start doing these meetings every Sunday, a moment of silence for all those who have died, for all those who have suffered, and for Dr. Susan Moore. And to think that her credentials did not protect her is simply evidence that race matters. And no matter how wealthy you are in the Black community, as a Black person, you are still Black. And our ancestors reminded us of that. Don't get too high on the horse. You are still Black, and you will be treated that way, no matter what your credentials. Now, I sent Dr. Maxey a number of background articles, but The one he called me about was this one here: allyship, anti-racism, and the strength of weak ties. A barber, a professor, and an entrepreneur walk in a room. And this is a story by Dr. Paul Terry, a meeting that the Robert Wood Johnson Foundation held at the Lincoln Lodge in Washington, D.C., the Lincoln Cottage, I'm sorry. And that was where Abraham Lincoln drafted the Emancipation Proclamation. And in this meeting, he describes his opportunity to meet Fred Spry, that's Fred right there, who's one of the Black barbers in our Black Barbershop Health Network, and Miss Kong, who is an entrepreneur out of New York City, and how that chance meeting in that space sparked new ideas and new innovation. And as you can see here, this is Mr. Terry. And I would truly call him an ally, a white male who wants to do the right thing for the right reason. And he's looking for ways how he can help. He's willing to take the chance of engaging in anti-racism conversations and learning. And I think that we need to create the space for that kind of multiracial interaction if we're ever going to get through this. And there will be pushback, and we need to figure out how to practice preparing for the pushback. In December, we brought together Black barbers and stylists. I believe this is how you meet people where they are. Many of you in this audience know that no self-respecting Black barber would ever say, I'll get you in and out in 15 minutes. And so it is a place where social norms are set. And so it's in that context that our work around building bridges, building trust, and building healthy communities is how we have translated the science of medicine and public health into culturally tailored community-based interventions. And I like to bring some of those voices in here. Here's another area where the Black Health Trust and the University of Maryland can collaborate. We have a organized training for building trust with the minority community and in helping researchers and providers become more self-reflective. We can talk about this during the Q&A. So history matters. We've talked about Tuskegee. At your last meeting, Dr. Maxey, people said we need to move beyond Tuskegee. I think we need to lean into Tuskegee. In some ways, it's the only reason we're at the table. If you look in the news, it is this historic misuse that is the justification for why we have to address these concerns. And the things that were used to get them in and keep them for 40 years, maybe some of those things could help us now. Think about it. Eunice Rivers was the nurse that kept them in together for 40 years. She cared for them. She loved them. They trusted her. All the things that she did should not be simply thrown out. We need to really examine our own history, the role of Tuskegee Institute during this period, and how we can take those lessons and apply them today. Yes, there was an apology, and I was honored to be at the White House on May 16, 1997, where Mr. Herman Shaw, a former sharecropper, and the president exchanged that apology, and it was accepted. But an apology means I'm sorry from a president who wasn't even alive in 1932 when the study began. What we need to do is move towards atonement, which means making things better. And I think the national campaign to eliminate health disparities and our efforts here in the Black Health Trust are part of that atonement, and to acknowledge the cultural memory that in some ways is protecting our people from abuse. So our aim should not be to disarm them, but to inform them so that they can make better informed decisions. And so it's in the ethics. This is one of the outcomes of the Tuskegee study, our bioethical principles we live by today. And I think the principle of justice is one that has not been lifted up enough. Justice means this: those who bear the burden of research should not be denied the benefit. That's essentially what this is saying. And Black people have borne the burden of research since our time here during slavery. We should demand the benefits of that research, demand access to clinical trials, demand access to the vaccines. So here's what it looks like on the ground. And Dr. Johnson, you may remember this because we started right here in Pittsburgh with our Health Advocates in Reach and Research, HARE. We now have a network of 10 shops here in the Metro DC area. And as you can see here, it's the only when you get exposed do you realize how truly amazing the Black barbershop and salons are. And I'd like to take you inside so that you can hear some of what we're hearing from the community. I'm going to come out and come back in, and I'm going to come back in. And again, I want you to cross your fingers for me because I want to make sure this works. And I'm going to take you in to hear the voices of our brothers and sisters in the shop. This is called the coronavirus edition. Here we go. You can control your sound.
This is my good customer, Brian. Been my customer for years. This is my good man, Jonathan Fox. This is my customer, Marcus, for over 10 years. This is my customer, Corey. We've been my customer for a few years. This is my good man, Larry Brothers. Will you take the coronavirus shot?
Nope.
Why?
Because it'll kill you.
How you know that?
Because it killed I ain't gonna say millions, but thousands and thousands of people.
I mean, I want to see what the how it works, because you have so many different companies that are coming out with vaccines under different nations, under different levels of pressure in terms of let's get it out.
I'm not gonna take that. I gotta see how it affects other people. Then I make that decision.
Vaccine. That's supposed to. I don't know if it's supposed to. Is it you throw the mask away after you take the shot, or do you social distance over? I don't know anything about it.
It's a good question. I personally feel like I said, another way for them to capitalize on this entire pandemic.
I believe that my body building antibodies against something is going to protect me better than putting a virus inside of my body, because that's what the flu shot is, and that's what this antivirus is supposed to be. I'm not doing it.
Okay. If people like Dr. Fauci said, put his okay on it, but as far as the president, what he said, I don't trust it.
But what he just took some stuff, had him back in a week.
Yeah, but we not gonna get the stuff that he took.
Right.
Not the coronavirus.
Why not?
Because it hasn't been tested at all. And even when they came up with the polio shot, I mean, that was like 20 years.
So
I definitely won't take that.
Why not?
Because I don't feel as though it's safe. You know what I'm saying? We don't know if the medical administrators are telling us the truth about this thing. I mean, who knows what's in this thing?
Yeah. So we just take our chances how we've been doing.
I mean, with me, not with everybody else. I'm just speaking personally.
Thanks a lot. All right.
Okay.
All right.
There it is. So let me head to the finish line and simply say that I think there are lessons here that we need to be where the people are in settings that they trust, that the barbers and stylists are not necessarily second-class health professionals, but with training, they can be role models. This is in the New York Times front page today. That's Mike right there, the barber. And they did a very nice job interviewing him, as he's hearing now over time, people are moving from hell no to no, from no to maybe, and from maybe, when do I get in line? And there is a lesson there. We need to stay with people, as Dr. Johnson said, plain language, using images and infographics. We have set up also a Instagram site. We call ours the Barbershop Health Box. And people in the barbershop simply drop questions in the health box, and then we respond with infographics on an Instagram channel. So we have the energy of the young people. We demonstrated how to bring saliva COVID testing into the barbershop. It's highly acceptable. You can't do what they do 6 feet away. Let's save them. Let's save this industry. This is a precious jewel in our community. There are no franchises, no supercuts or hair cutlery. We need to make sure they make it back, and there's no guarantee. So I think that the Black Barbershop and Salon is ground zero for us to help to educate our community, to bring medical and health services into our community, to help people follow the COVID mitigation guidelines, and most importantly, for us to listen to their concerns so that we can address their needs from their perspective. Let me stop there. I think the conversation is going to be the most important part. And thank you, Dr. Maxey, for allowing me an opportunity to speak.
Thank you, Dr. Stephen B. Thomas, for this astute and thoughtful presentation. And I'm sure we're going to want you back to look at some of the other ideas and things that we've been talking about over the months. Dr. Neighbor Stevens, do we have any questions in the chat box?
She's muted. You're muted, Dr. There you go.
Thank you. A lot, as I said before, we brought Dr. Thomas on, that there were a lot of questions generated by the first two speakers that I think that he hit dead on. And I think that, and I want to ask the question not to diminish the impact of what you're doing, but just as a practical point, you said you hadn't gone to the barbershop to get your shave, and I haven't been going to the beauty shop to get anything done at the beauty shop. So if we're not going to those places, what other opportunities are we perhaps missing that we need to identify and capitalize on in this overall effort to get the information out?
Well, one of the things that we've done is to bring the barbershop virtual. And so I think part of it is thinking differently. They're under conditions of they can't congregate, they have only a certain number of people at any one time, and any Black man on these Hollywood squares knows that that's where the energy is. It's hanging out, listening, talking, the socializing. How can we, in this moment we're in right now, create a space like that right here in Zoom so that they have that space? We brought them in to these spaces to interact with people like Dr. Michael Osterholm and the other leaders in the Biden task force. And I think that's very key for them to be able to have access to that kind of expertise. The church is under the same thing, Dr. Stevens. The churches, again, you can't congregate. How do we use Zoom to create the virtual space for that kind of fellowship? It's an opportunity that we have to harness.
There is a comment in the chat from a dentist who wants to know, has the dental profession been brought in any way in these new attempts to collaborate and disseminate information?
Let me just briefly say, I love the dentist. I'm so glad you put that in there. We do what's called a mission of mercy. I don't know if you're familiar with that.
No.
Turning our basketball arena into a 125 chair emergency dental clinic, serving 1,000 people over 2 days. I think dentists are key. I'm a member of the Maryland State Dental Association, and we have the dentists helping the barbers practice the mitigation guidelines. So our Maryland Dental Association will give their stamp of approval for those barbershops that meet the mitigation guidelines. And that's how we've reached out to the dentists. I think they're vitally important.
May I make a comment, Dr. Neighbor Stevens?
Certainly.
My comment and then a question is with the dentist, it's probably a one-way conversation not from the patient, but from the dentist. Nobody can talk with that stuff in their mouth. But number two, I liked your paper that you sent me about developing allyships. I'm wondering if you'd comment on how that can play a role in bringing these messages and creating organizations and practical approaches to mitigating this pandemic and health disparities in general.
Well, one of the things that Paul Terry said when we were sitting around that table, as he met Fred for the first time, was that as a white male, he has no kind of anxiety walking into, a Black soul food restaurant or to a barbecue place, or but that a Black barbershop felt so personal. I see Reverend Kinzer out there, Reverend Pointer. It's so personal. He felt some anxiety, like maybe he would not be welcomed. And so around that table, as Fred told him, I have my license, I can cut all hair. And so I think we have to simply create the space for that allyship to take root. And I think that where I'm planting my flag, I think the barbershop's one of those spaces. Not the only space, but it's one of those spaces. I think we need allies. We need people at the table who can knock down some doors for us. We need some people who are in the room where it happens. We're not always in the room where it happens. I want to know who's following up on the good doctor who just told that story. You know, that's the hospital version of the George Floyd. Who is holding that institution accountable? Who's following up? Those are things where we can, I think, apply some pressure. They don't know we exist. They don't know the Black Health Trust exists as a place to come for help and advocacy. They need to know that this organization exists for them.
Now, I'm glad you brought that up because earlier there was a comment about or question around whether or not the information that's being supplied by CDC is reliable. And I guess they would lump FDA in it as well. They didn't specifically speak to FDA. And I think they were asking, what is BHT? What role does BHT have in all this? I want to again re-emphasize that we at BHT and the medical advisory group are not accepting the word, so to speak, of anyone. We are looking at the science. We are looking at the evidence, and based on the information review, making our very deliberate determination as to what we want to recommend and not recommend. I want to redirect you to the opening remarks that Dr. Maxey made regarding our relationship with National Medical Association's task force on COVID. We have reviewed their statement, and based on the information and the statement that they made the determination that we supported their statement. The critical component to all of this is reviewing the evidence, looking at the science, not listening to opinion, not taking in the conspiracy theories, but looking at the information. There have been a couple of questions today, and I'm really happy to see them because it's an evolving story. Questioning what are the alternative therapies that are being developed, since we know we cannot just rely on the development of vaccine. And we have actually had a couple of talks on this. So it means that we need to revisit these subjects again after the new year, because there have been some new things that have developed since we last discussed this. And that's what I want you to understand BHT is trying to do, is to bring the credible information to you.
If I can comment on top of what you said, Dr. Nabet, which I totally agree with. As you mentioned before, I'm a consultant in medicine. I'm a nephrologist. And one of the things that I learned well is that I cannot take another physician's, another scientist's word just because he wrote it. When he sends me a patient and says this patient has renal failure, he needs to be put on dialysis, I can't do it. I have to reevaluate my own terms. Does he meet the criteria? Is his EGFR, is his kidney function of the right level? Is his laboratory at the right level? And in every case, I must make my own judgment. I pictured myself in front of a judge, and the judge said, "Why did you do this to a patient?" I said, "Because Dr. So-and-so said he needed it." And the judge would say, "Didn't you make your own evaluation?" Well, the Black Health Trust is making its own evaluation of not only the CDC data, the FDA data, the Pfizer, the Moderna, and any other of the companies that are creating these vaccines and health plans and giving them to the NMA. And even though we are members of the NMA, and I'm a past president of the NMA, we still reevaluate their conclusions. And we come to independent conclusions that we present to you as potential advice to be rechecked by your physician before you do that. So we're trying to be the best we can in terms of giving recommendations and giving data to the best of our ability. Even so, as Dr. Neighbor Stevens said, medicine is not an exact science. We know that even though we like to say things should go through a blinded trial, that's not always the only way to get to it. A lot of the information that we also must look at is observational data that isn't necessarily funded by multi-billion-dollar interests, but we're doing our best to bring the best of credible information to you. And that information will change from month to month as we learn more and more. But we will always try our best to bring you the truth as we see it. To this end, our advisory committee is meeting again next week, next Wednesday, and we're going to have a speaker who's going to be speaking about some non-mainstream treatments of COVID. Dr. Brownstein is going to be our speaker, and we invite all of our physician members to come to that meeting. And we're going to have a debate over the treatment and try to bring the best out of that again as we move forward. We're trying to be as intellectually and spiritually honest as we can to protect our communities. Are there some questions that apply to all of our speakers? Let's give ourselves a few more minutes to see if there are any questions for Dr. Maxey, the young Dr. Maxey, as she's described, and Dr. Rhonda Johnson and Dr. Stephen B. Thomas.
I see Kinzer has his hand up, Randall.
Okay, go ahead.
Yes, thank you for doing this. Certainly, as a pastor who
Got to
leads a
introduce
consortium.
yourself. Introduce yourself, my brother.
I'm Pastor Kinzer and Pointer. I currently serve as the chair of Millennium Collaborative Care, which is a sister organization to the largest public health concern in Erie County, actually in Western New York, Erie County Medical Center Corporation. I'm also the president and CEO of a consortium of 68 African American and Latinx churches who have spent the last 10 years working in health around the social determinants of health and the persistent health disparities that assail our people. I'm incredibly encouraged by the work that is being done by the Black Health Trust. And I want to know, what is the process for not just reaching out to the Black Health Trust, but including you in our work? We're currently doing a COVID response project in Erie County that we were able to get funded. And so far, we spent about $4 million responding to the COVID pandemic by educating people, by leading people to where they could get tested, as well as creating relationships with African and other primary care physicians, providing food and dry goods to people in their homes, so that when we went to New York Pause on the 15th of March, people could actually shelter in place because we're in a community where 40% of children live in poverty. And you can't tell people to stay home when they have to eat. So we just simply responded to that. We first were supported by the Medical Center Corporation, and now we're supported by Erie County. And I just concluded an agreement with the county to continue to fund the project that we're running into 2021. So I'd just like to know, how do we link up with the Black Health Trust so that we can learn more in this community, especially around this issue about giving people information around the virus. But not just that, but help people understand the critical need to move based on data and information that comes because of science.
Well, I'd like to invite you, and I'm going to give you my personal contact information right now. And my cell phone is 310-686-8490. And my email, my personal email outside of Black Health Trust is randall.maxey02@gmail.com. And I'd love to talk with you tomorrow. I'm trying to be a family man today, what remains of it, so I don't have to sleep on the couch. But if we can talk anytime starting tomorrow, I'd love to do that. And I'd add Dr. Neighbor Stevens with that, and we'd love to talk with you and work with you. And all of our other speakers and all of our other, we're not some big corporate organization. We want to connect with everybody. And if you want to bring something to the table, we'd like to invite you. Thank you so much, Pastor.
Doctor, can you repeat that phone number for me?
310-686-8490.
Okay, thank you. I commit to calling you tomorrow morning.
Thank you. Dr. Neighbor Stevens, let's take a couple of questions before we go off if they're related to the speakers.
Actually, we're in good shape. I think that the combination of our three speakers addressed most of the questions. And as I said, we will bring forward a program addressing new therapeutic opportunities and updates as they become available on the vaccines after the first of the year. And we look forward to seeing everyone next Sunday.
And Dr. Maxey, you had 78 people on here, brother. You did wonderful today.
Well, thank you so much. I understand somebody asked also for the contact information for the biometrics second opinion expert. That email is biometrics, BIOMETRICS dot secondopinionexpert.com. And that number, that will get you to the website for the second opinion. And for those doctors who are interested in joining as consultants, we have a vetting process. Please contact the Black Health Trust, contact me, or even through that website, and you will be responded to. And as last resort, talk to me. And I'd like to appreciate and congratulate all of our speakers. The young Dr. Max, I emphasize the word young. Also the young Dr. Rhonda Johnson and the young Dr. Stephen B. Thomas. We certainly appreciate you. And I appreciate Dr. Helen Davis for helping with bringing on the speakers we've had today. And Dr. Barbara Neighbor Stevens, who's been my operating partner, and Simon and N2, and the other people who helped make this program work. Our committee on administrative matters, we meet every Wednesday. They put up with me and we figure all of this stuff out. We do need your contributions. We do need your help to grow, and we appreciate everyone here. Is Ms. Brenda Lee Yeager on? If she's not, Pastor, I'm going to call on you again since you had a question. Would you give us a brief prayer of benediction?
Be happy to. Let us bow and give thanks. O Lord, our God and Father, you who are the wise maker and creator of the heavens and the earth, the giver of every good and perfect gift, we thank you for this time to share together, to learn, to discover, to renew. to link our arms together and to do work that would bring some comfort and relief to the people that you have assigned to our trust. We ask, oh God, that you would give our hands work to do, and that you would give us the strength and the energy to carry out that work. As we leave this congregation, albeit virtual, we ask for your continued presence and your guidance. We know that you're able to do all things but fail. Open our hearts and ears that we're sensitive to the suffering around us, and that we resolve that we will do everything we can to end it. And we'll be careful to give your name the glory, the honor, and the praise forever. In Jesus' name, amen. Thank you.
I'd like to also recognize Dr. Ida Marie, who wanted me to make sure that we celebrate the tenets of Kwanzaa. Have a good day, everybody.
Bye-bye.
Bye-bye.